So what do you see in this? What is the pattern of presentation in the CT scan? Right? What do you see in the CT scan? Are you seeing some radiolucent areas or radiodense radiolucent? So it is a cyst. How will you differentiate cyst from emphysema? Wall. So here you cannot make out in few cases you are able to make out, but most of them do not have the wall. So it is a classical cystic lung disease. So cystic lesion. So if your patient is having jaw grunts, what will you suspect when you have cyst? LIP. So this is a case of a lymphocytic interstitial pneumonia. So what do you see in this PFT? What is the FE1 by FEC? No, is it normal or abnormal? Normal. So what is the abnormal presentation here? FEC is 65. Is it normal or abnormal? Abnormal. So the volume of the lung has decreased. So DLCO increased. So what are the conditions in which DLCO will increase? Okay, we'll start from here. What are the conditions DLCO will increase? Your good name? Imran, in which condition DLCO will increase? Asthma, yes. DLCO will increase because vascularity will increase. Then, when hemoglobin increases, polycythemia, DLCO will increase. So where else DLCO, in which other condition your lung blood will increase? Alveolar hemorrhage. So you have a patient with an SLE and you have a high DLCO. What you will suspect? Diffuse alveolar hemorrhage. Good. So next person. So what is this findings? Please stand up. What is the finding and what are you seeing in the CT scan? What do you see in this? Generally, you don't see consolidation in the mediastinal window. So in parenchyma, if you see, it looks like a mass or a consolidation, but the same thing is also seen in the mediastinum. So what is it? Anybody? High attenuated mucus plug. Can you see this dense lesion and you compare it with your paraspinal muscle? If the density is more than the paraspinal muscle, you will call it as high attenuated mucus plug. So why it is high attenuated mucus? What is the pathophysiological mechanism? It contains more of calcium and magnesium. So it appears more radiodense. And what is the condition? First year? Huh? Okay. So it's a classical case of ABPA. If you see a like this, what happens is many patients will be treated with ATT. Few people will undergo biopsy. If you just order a serum total IG, you will get the diagnosis. Okay. So next person. What is this you are seeing here? What is this radiological sign? It looks like crazy behaving, but it's not crazy behaving. But see, it's okay. If you have made till crazy behaving, that means relatively it is correct. So, but how it is differing from a crazy behaving? Isn't it looking more dense? Like if you see the spots, it is looking almost taking the density as of your bone. So what are you seeing here? It's a case of pulmonary alveolar microlithiasis. What will mimic like a bone? Only a calcium deposits will mimic like a bone. So what you are seeing here is a classical black pleura sign. Okay, the pleura will appear black. This is called black pleura sign, and it's a case of pulmonary alveolar microlithiasis. So next one. Ma'am, your name? Shri Priya. Which disease is not associated with ILD? Is vasculitis associated with ILD? Yes. Lymphoma? Yes. Be it because of disease or be it because of treatment, it can be associated with ILD. HIV? Yes. So what is the answer? CVID. Okay. Simple one. Next one, behind. So what is this SMART? We had a discussion in the morning. Which one will you choose? Why? It's both rapid acting and long acting. Okay, that is why you choose formoterol. Whereas your salmeterol is long acting, it is not fast acting. Okay. Next one. This is a simple one, no questions. Down. Winner, what did you answer? Parenchymal. These are all very objective. So the most common finding is parenchymal bands. Next one, another stethoscope winner. So halo sign. So why halo occurs in aspergillosis? What everybody knows, aspergillosis will cause halo. What is halo? Okay, very good. Aspergillus will cause angioinvasion. So what happens? When angioinvasion by fungus happens, what will happen? It will bleed. So all that bleeding which is surrounding your nodule, what you are seeing is the halo. Okay. So this is a case of invasive pulmonary aspergillosis. When you see the halo sign, it is an early form of invasive pulmonary aspergillosis. Okay. In your later forms, this nodule will go in for cavitation. So when you see cavitation, that means it has already become a little advanced. In early stages, you will get this halo sign. In which other condition you will see halo? Okay, even I forgot you read. There are many other conditions also. Not even in your vasculitis you can get halo, because again it involves your blood vessels. Okay. So what is this condition? 43-year-old admitted with cough, recurrent pneumonia, CT chest, left lower lobe mass. What is this you are seeing? What is the abnormality you are seeing here? Yes, very good. But why? What you are seeing in the CT scan? Yes, exactly. You are seeing the blood supply to the pulmonary parenchyma directly from a systemic artery. Okay. So whenever you have got a recurrent pneumonia occurring at left lower lobe persistently, you have to ask for an angiography. Only with an angiography you will know the blood vessel is supplying to the sequestrated lung or not. Next one. Identify the sign. Which condition you will see most commonly? Which one? Mucor. Next. Organizing pneumonia. Very good. What is the other name it is called? Atoll. Other name? Birdnest sign. Good. Sometimes you can get in vasculitis also. Okay. What is this sign? Next one. Hilum overlay sign. Very good. So next person, this side. Ma'am, you can start. Yeah. So what is this you are seeing in the bronchoscopy? How will you describe this bronchoscopic image? Okay. Okay, mass is there, but any better description? Very good. It's highly vascular. Then, is it smooth or nodular? It is relatively nodular. Yes. And is it pedunculated or sessile? It's almost like pedunculated. The importance is, if it is pedunculated, you can easily put a snare. Okay. So when you see like this in a young patient coming to you with hemopsis, what will you suspect? If you are doing a bronchoscopy, you are seeing this, you will go and take a biopsy immediately. Yes or no, you will take biopsy or not? Then patient will bleed to death. You have to be very cautious. When you see such a thing, you should always suspect carcinoid. Okay, when you see a pedunculated mass lesion which is highly vascular, always suspect carcinoid and never try to attempt a biopsy without proper airway protection. These patients may bleed very severely. Okay, so this is a case of a carcinoid syndrome. Next person. So what are you seeing in this? ADA is 37. Very good. It's a sago grain. Okay, sabudon. The same appearance. So when you will get a sago grain appearance? Miliary, any sort of pleural TB can have sago grain. Okay. Miliary TB, you will get choroid tubercles in the eyes. Okay, last one. Did anybody get this answer? Okay, we'll ask from everybody. Which one? What is it? For TB. Which one? This one or the last one? This one. Where is the pustule in this? What is this image basically? What are you seeing? Which anatomical structure you are seeing? Which anatomical structure you are seeing? Which part of the lung which part of the thoracic you are seeing? Okay, you are very near, but not exactly. What else? Aren't you seeing something totally hypoechoic? When you see hypoechoic, what it is in ultrasound? By fluid. So where all fluid can be there in the thoracic cavity? Pleural effusion. Apart from that, blood vessel. Very good. So what you are seeing here? How can I see a blood vessel? In which investigation I can see a blood vessel? With an ultrasound, as a pulmonologist, where you will see a blood vessel? EBUS. Right? So what you are seeing inside that? Exactly. Pulmonary embolism. Sometimes here in your EBUS you can find a filling defect. So this is a pulmonary embolism. Okay? Okay, that's it. Thank you.